Thank you for watching The Abundant Life today. I'm so excited to have a special guest with me. Her name is Dr. Raushanah Hud-Aleem. So you can't afford to miss this, so stay right there. We will be right back. Okay, welcome back. So today I have with me Dr. Raushanah Hud-Aleem, and we're going to be talking about depression. And I am very excited to have her because she's someone I've worked with. I know her, and she's very passionate about mental health awareness. She is a board certified psychiatrist and a board certified child and adolescent psychiatrist. She's a nationally recognized author, speaker, consultant. She's a best-selling author of Prehab Before Postpartum, a prenatal anxiety and depression guide for a happier postpartum. She attended the Ohio University College of Osteopathic Medicine and graduated in 2004. She completed a general psychiatry residency and a child and adolescent psychiatry fellowship at the Wright State University Bunshoft School of Medicine in Dayton, Ohio, which afforded her the opportunity to train in both rural and urban settings. She's a chief medical officer for Project Rebound and the medical director for Eastchester Family Services. She's also the CEO of Radiant Light Psychiatry, private practice, and the co-host of the Duality of Vitality podcast show. That's a great show. A podcast created by her and her sister, Dr. Zarina, American Pain Freedom Doctor. She has been married for 19 years and is the mother of 4 beautiful, adorable girls, and passionate about promoting mental health awareness and stigma. Okay, so I'm so happy to have you to talk about depression. It has been a difficult year, 2020, and depression has been rising before COVID, you know, and I know the numbers are even more now. And I just want to talk with you today about the different types of depression, how does it present in different ways, and just your process of diagnosing and treating people and medication. But before we get into that, you talk a lot about, decreasing stigma. And I'm very curious to find out, how do you help people to be more comfortable with talking about their mental health challenges?
Well, thank you for having me. I'm so excited that we are finally doing this. I have worked with you, and I think you are one of the most wonderful social workers that I ever worked with. So I'm so excited. So stigma, woo. So I guess the way that I approach stigma with the individuals that I see, I often think about the stigma that I have once held. I try to remind myself of how that has impacted myself or others from seeking the help that they need. I say that because I myself have dealt with postpartum depression. Hence, that was one of the inspirations why I wrote the book that I wrote about trying to prepare, trying to become informed about anxiety and depression that occurs during pregnancy and after pregnancy, and decreasing that stigma. Because I myself, psychiatrist, held some stigma.
Wow.
I was very reluctant to express or share that part of my life. And so I think one of the best ways to fight stigma is to talk about it.
Yes.
I think stigma tends to prevent people from talking about it, from sharing, from seeking the help that they need. And so subsequently, they end up suffering silently. So I often tell them that, people don't just say, oh, I just want to become depressed. Sometimes depression occurs because of different circumstances, maybe biochemical things that's going on in the brain. But I also try to relate to them that it could be a biochemical cause, just as like diabetes or high blood pressure or other physical health issues. So mental health is just as important. I'm a firm believer that what affects the mind affects the body, what affects the body affects the mind. And so I try to come up with examples and show how, they will, oftentimes people won't hesitate to seek the treatment that they need for physical ailments. And so encourage them to do the same for their mental health. Because at the end of the day, our minds is the captain of our ship. If the captain is not well, that ship will go off course. So it is very important that we talk about mental health and be okay. One thing I realized once I became interested in becoming a psychiatrist when I was in medical school, I realized that the more I learned, the more I realized there are a lot of people, there are millions of people out there struggling.
Yes.
And we push it to the side and say, oh, that's just auntie, that's just the way they are. Or, no, this is just temporary, but temporary continues to go on for years.
Yes.
Right? And so it's a lot of us who are out there suffering. And the only way to help reduce the suffering and to improve and encourage mental health wellness and physical wellness is to acknowledge it, to accept it, and let's do something about it.
You've made some very important points. So it's just being aware, like education and talking about it. And I think just sharing that as a psychiatrist, that you also had a personal struggle, and hopefully we can discuss that some more a little later. But thank you for sharing that.
No problem. One thing I think is also important, especially for communities of color, I think our historical experience has perpetuated some of the stigma, because of the inequalities and things like that we've gone through. We have had to adapt to our environment, and we have taken on the persona of being very, close-knit and keeping things a secret and portraying this picture of strength, which we are. But I think to a certain extent, because of what we've had to go through, we've kind of ignored some of those other areas that are essential to our mental health. So I think in addition to this, that's one of the things that can perpetuate stigma is just our cultural experience, our historical experience has perpetuated that.
That is so true. And even though we're from different places, I'm from the Caribbean, you're from here in the United States, but it's interesting how much we have in common in terms of that experience and how we view mental health. I've enjoyed working with you, and I must tell you, I'm grateful for you because people have had many different negative experiences, as you said, with doctors, psychiatrists, and not being thoughtful and careful and educating their patients about what they're doing, and you do that. You take the time to educate people about what's happening with them, and just understanding that struggle and connecting with that to help them to go to a different place. So I appreciate that, and I know that you have touched a lot of lives. So depression. So the series I'm doing on depression, I think the goal is really to educate right? And to reduce the stigma around it, and just to help people to understand better how to identify when they're struggling, and just how to cope and how to seek help and when to seek help, right? But depression has so many different presentations, right? It's just a lot, you know? So can you talk a little bit about that, like the different ways that depression presents?
Yes. So depression can present in many different ways. I first want to say that, remember, depressed mood is different from clinical depression. We all at some point might experience a depressed mood for different various reasons.
Mhm.
But one of the things that I always will try to educate my patients about is that what distinguishes a, a certain or specific occurrence circumstance from like actual diagnosable like depression is, number one, how long have you been experiencing the symptoms? What other symptoms are currently present? And is it interfering with your ability to function? Perhaps it's interfering with your social, your relationships, maybe perhaps your work environment or school. So one thing is to identify first, am I depressed? Am I experiencing a depressed mood?
Right.
If the answer is yes, okay. Depressed mood by itself does not mean you have depression or major depression. What other symptoms are involved? So in general, people think of, so again, many types of depression. But the first, I would say the most commonly understood and known one is major depressive disorder, okay? Then you may have other depressions. For instance, you may have psychotic depression, perinatal or postpartum depression, bipolar depression, persistent depressive disorder. So there are a lot of different depressive disorders. I use depression is almost like an umbrella, an umbrella term because there's a number of different depressions. So you might say, same thing like maybe a car. I may say, here's a car, but you have different types of cars, right? So you have depression, you have different types of depression, okay? And so, again, it's an umbrella term meant for a variety of different disorders. So one of the things I do is, are you depressed? And so then I try to understand what might have been the trigger. In your previous video, you probably talked about causes. Sometimes it's a biochemical cause, sometimes it may be situational, stressors, trauma, okay? And so I try to, when I'm talking to a new person or a patient about depression, I'm trying to really get an understanding of what their experience have been up to this point. When did the depression start? And then how has the depression impacted or changed or impaired their ability to function day to day?
Okay. So that's good for us to know that it presents differently. And I think many people do not know that, Two types that kind of throw people off is the depression with the psychotic presentation. I want to hear a little bit more about that, and bipolar.
Yes.
We hear about that. We hear a lot about bipolar in the media. A lot of people struggling. They've been open about their struggle, but it presents in
differently.
So those two, I think. Can you talk a little bit more about those two?
Yeah, bipolar. That's a term that's thrown around a lot, and irresponsibly sometimes, and I think it could be hurtful because not just because someone is irritable and moody doesn't make them bipolar. Let me put that out there.
Okay.
Sometimes, she's bipolar, so she has these moods. That's bipolar. No, let's not do that. Let's not do that. So one of the differences between bipolar disorder and major depression is major depression is considered what we call unipolar. So oftentimes I'll talk to my patients about, okay, let's say this is where, the normal mood, you have little ups and downs, but they're not extreme, okay? And so unipolar. Uni means one. So with major depression, there's a change in one direction, right? So you have a depressed mood. You might have appetite or sleep disturbance. You may have suicidal ideations. You may have problems with energy, concentration, okay? And so there's a change in one direction, okay? With bipolar, okay, you can have a major depressive episode, but bi implies two. So you may see in bipolar, you'll see changes in two directions. So this is where we want to be, but sometimes with bipolar, you may have depressive episodes, those symptoms that I mentioned, and and of course, those symptoms are occurring for a minimum of 2 weeks, all right, or longer, and it's impairing function. But also with bipolar, you may have the opposite of depression, which is called mania. And mania is often considered the opposite of depression. So we're not talking about, oh, I'm feeling good. I feel really good about life. It's mean like you're like, with mania, you may have decreased need of sleep, so you're sleeping less. You can't concentrate as good. You may be more talkative. You may be more focused on certain things. Maybe instead of sleeping, you're more social than usual. It's a change in your personality, what is normal for you. Sometimes people will say, I will clean and clean for hours, or I'll become more social, talking to strangers randomly, not thinking about consequences. Sometimes people will spend lots of money that they can't afford to spend, or they may become more interested in things that they don't ordinarily do. Maybe drinking more, maybe becoming more promiscuous, okay? So this is the opposite of depression. So with bipolar, you have, again, two poles, changes in your behavior and mood. And with major depression is unipolar, you just have one change, okay? And so with bipolar, it's not those symptoms that I mentioned just for a couple of hours. We're talking about those symptoms, and of course, sometimes with bipolar, you can also have psychosis, so hallucinations, paranoia. You can have grandiosity when we're talking about feeling more confident than usual, maybe to the extreme that some people may think that they have special powers, special abilities. Okay, and so, but these symptoms are occurring on a consistent basis for a certain amount of time, for at least 7 days consistently in a row. Oftentimes, if it's not treated, it will go on longer. But this is a little different. This is the difference between bipolar, which is what we call a cyclic, because it kind of can go like this, where versus major depression, which is a unipolar, you're not going to have that mania. But this is the caveat. Bipolar is one of the most challenging mood disorders to diagnose, because all you have to have had is one manic episode in your entire life in order to meet the diagnosis for bipolar.
Okay.
So sometimes what happens is people may not remember that episode. So by the time they come in, especially if the manic episode was not as severe, or if it was a long time ago, people will come to me because they're feeling sad. They're in their depressive episode, and they may not recall that period of mania. So they say on average, it can take sometimes up to about 10 years before the person actually gets the diagnosis of bipolar, because it's really important for us to know and understand the history so that we can put it in context, because there are risks of treating someone who actually has bipolar, treating them with just medications that we would typically use for a major depression. So it's very important that we distinguish between the two. It's very important that we as clinicians get a very, very thorough history. And I can't get a thorough history in 15 minutes. I can't. So it's important that we get a thorough history, and it's important that the patient try to be as open and honest as possible. Because the other thing about just mental health illnesses in general, the longer we go without treatment, the longer we will suffer and the more challenging it may become to help those symptoms improve.
So that's it. That's the power of early intervention, right?
Yes.
So you talk a lot about the history. Getting history is important because you mentioned that the medication for treating bipolar is different.
Yes.
From the ones you would use. So the treatment plan is different.
Yes.
It's important to get that understanding. In terms of depression and psychosis, how does someone move from having depression to having a psychotic episode?
Yes. So psychosis is just a term, an umbrella term for certain symptoms. Okay. So psychosis, just because a person experiences some psychosis doesn't mean that you're schizophrenic, doesn't mean that you're bipolar. Because sometimes that's another thing that will keep people from seeking the help that they need. Because if they are experiencing, for instance, some examples of psychosis may be auditory, where you're hearing things, or seeing visual hallucinations, paranoia. You may have grandiosity. So these are some examples of like paranoid delusions. These are examples of some psychotic symptoms. Psychotic symptoms does not necessarily equal, again, schizophrenia or bipolar. You can have psychotic symptoms when you're depressed as well. So I think sometimes people experience it and they're like, I'm not going in because, and I don't like this word, I think it's a bad word. I tell my patients all the time, ooh, that's a bad word. That's a curse word. When they come in and they say, I didn't want to say anything because I don't want people to think I'm crazy. Crazy, I don't like that term. But I think that keeps people, people are afraid to share that because they think that automatically means that I must be schizophrenic or I must be bipolar. So one of the ways to distinguish it, again, it goes back to taking a careful and a thorough history, trying to understand what presented first and how is it presenting and how long has it been presenting. Oftentimes with psychotic depression, you'll have the change, that unipolar change, and you'll get the major depressive symptoms. But then in the mix of that, then you will experience the psychosis. Okay. Oftentimes with, for instance, schizophrenia, the predominating symptom is going to be the psychosis. So you may have psychosis irregardless if you're depressed
or not,
or irregardless if you're manic. Okay.
Right.
But the predominant symptom for psychotic depression is the depression. Okay. And so sometimes that depression the psychosis that may accompany the depression might be what we call congruent with the mood. So they may have things like they're having hallucinations, and maybe the hallucination or let's say the delusion somehow they're just less than, or perhaps they have this delusion that anyone that touches them is going to may get sick or things like that. And then you have some that are not mood congruent or they're mood incongruent, and they don't involve the depressive themes. Okay, but the psychotic disorder versus a psychotic depression, get a thorough history. The depression is the most outstanding or the most noticeable thing. You'll get the depression usually first if you get a really good history, and then you'll begin to get the psychotic symptoms.
Okay, that is very helpful. And I hope people are able to see and hear the difference and understand that, they're not necessarily having schizophrenia, for example, but it could be mood related. Another thing is the biology of it, right? Like, how do you rule that out? Like, are there other issues in the body that can contribute to people manifesting depressive symptoms?
Absolutely. So one of the things that, anybody who's a psychiatrist that might be listening will say that in our training, we are taught that first things is first. The first thing we need to do is rule out any physical, medical reasons for the mood disorder, because we want to make sure there's no physical reasons or physical health issues that could be contributing to it or be the cause, because there are some that can make it look like depression. For instance, there's sometimes there may be thyroid issues. Thyroid diseases can not only paint a picture or present a person, or a person can present as if they may have a major depressive disorder.
Right.
I've seen it personally when I've treated patients where it made them look manic. Okay,
Wow.
so they can appear, yes, they can appear as if they're manic. I've seen it also, which is a different topic, but come across as obsessive, OCD, some obsessive compulsive type symptoms as well. So physical medical issues can alter or influence the brain chemistry and can present as a primary mental health issue, but it may not be primary. Simply treating that physical medical health issue may help resolve the mental health issues that they're experiencing. Other things that can happen is sometimes we have people who have what we call comorbid issues or other issues, like maybe they have high blood pressure, or maybe they have asthma. I say that to say there's sometimes some medications that are not for mental health, is not prescribed for a mental health issue,
Right.
that can cause mental health symptoms. So there's sometimes when I'm treating children in particular, for instance, they may come to me and perhaps they come in and they're on a medicine for their asthma. So I have to take that into consideration. Is this why the child is presenting to me? Does the medication have anything to do with it? Because sometimes medication can also cause mental health symptoms. So first things first, oftentimes when I see someone, I'm automatically thinking, is there any physical medical reason for these symptoms? And so I might draw lab work. I might get records from whoever their primary care physician is. And I'm going to do all that, but I'm also considering, is this a primary mental health issue? So definitely, that's a great topic and question to talk about, because it can be due to a physical, medical, or medication. That's why the person is presenting with a mental health symptom.
Wow. So that is just mind-blowing, right? How complex this is. And that's why when people try to manage this on their own, it becomes, difficult. They end up with a roadblock because it's so layered. That what you just said is there has to be a holistic type of approach. You have to get your blood drawn. You have to look at the history. It's so many pieces why you need a trained professional to support you, if depression is affecting your functioning. So I hope this helps people to kind of see that, seeing a psychiatrist who is trained is important, right? And having connection with your primary care and working together, because it's obviously critical in, at finding out what's really going on, and then at treating it in the most appropriate way.
Absolutely.
Knowledge is indeed power. Go ahead.
I would say also this, the fall is coming, and another potential thing that can cause depression is lack of vitamin D. So fall is coming, winter is coming. A lot of us we're going to be inside more. We get our primary source of vitamin D from the sun. So low vitamin D has been shown to be connected to depression, also schizophrenia, amongst other things. But so, our diet, I say that to say our diet, our physical activity, all of that plays a part in having overall and general good health.
Yeah. Thank you so much for that. Vitamin D. Who would know, right? That vitamin D can impact depression and schizophrenia. Who would know? So you work with children also. Is there anything you like to talk about in terms of, how depression might present differently in children or teens?
Yes. So children, of course, there are exceptions, but in general, you may see children have a lot of irritability, more so than depressed mood. Not that they can't, but you'll see more irritability. You may see acting out. You may see somatic complaints, so stomach ache, headaches as well, those type of things. But with children, I try to, it's going back to taking a very good thorough history of what life is like at school, at home, because sometimes kids might be being bullied, or maybe they're not having good eating, healthy meals or whatnot. But generally, children will present more with irritability, especially the teenagers, and that could be tricky. Because you're like, okay, is this normal adolescence or is this depression?
Exactly. That's a challenge. That is very challenging.
It can be. But going back to one of the earlier statements is, what symptoms are presenting? Is there depressed mood plus those other ones? How chronic? How often is it happening? Is it pretty consistent?
Right.
And how long is it going on for? And is it impairing their function? So basically, what was their function before you noticed this change? Were they doing well in school? Were they less forgetful? Things like that. Were they less isolated? So those things are important, because again, certain things we expect at certain developmental ages, but it doesn't mean that it's abnormal. But it is abnormal if it's happening consistently, if it's impairing, right? And definitely if it's triggering thoughts of not wanting to live and suicidal ideation.
Yeah.
Another thing that's interesting is we do feel like hormones can play a part.
Yeah.
Generally, girls and boys up until puberty, their risk of depression is the same. Okay. But once we hit puberty, depression in girls surpass the depression in boys. So there's a hormone component as well. So generally the children, you can have sadness, crying, isolation, but you may see more externalizing type of behaviors, acting out, being oppositional, defiant. As you get into the teenage, you're going to see more snappy irritability, isolating, okay? But there's another disorder that is kind of fairly new.
Okay.
And it's called disruptive mood dysregulation disorder. And this is a diagnosis that is diagnosed in children and adolescents. And it basically is when a child may have difficulty regulating their moods and their emotions, and in a way that is age appropriate. Okay. So for instance, ideally is, developmentally, we don't expect to see a 12-year-old having a tantrum like, let's say, an 8-year-old, right? So we're looking at, okay, so if you have a child that's having a hard time managing their emotions, they may have exhibiting a whole bunch of temper tantrums or temper outbursts in response to frustration, either verbally or behaviorally. This may be an indication that they have dysregulation, DMDD, disruptive mood disorder.
Okay.
So basically, the other thing about that is, so you have the irritability, you have the outbursts, but the way it looks, again, you got to get that good history. Between the outbursts, does their mood return to a normal mood? Or between the outbursts, there's like this persistent, insistent irritability between those temper outbursts. Okay. And so this is a diagnosis that was studied, and I think that what they found was a lot of these kids historically were being labeled as having maybe bipolar, but they realize that it's a totally different diagnosis than bipolar. And the majority of individuals that may have this diagnosis do not end up developing bipolar later on.
Okay.
So yeah, so that is usually, DMDD is usually diagnosed in children, disruptive mood dysregulation disorder. And it is not bipolar. It does not mean the person is going to become bipolar. And with DMDD, you're not going to have mania. You're not going to have manic episodes, but you will have outbursts and that persistent irritability.
Okay. That is good information. And as parents who are out there, if you are wondering about your child and the changes in their mood, that was key to just kind of help you to kind of identify if there's a problem. And please don't hesitate to seek and talk to a professional, because obviously it can be very helpful if we intervene early. Once you're concerned, your children, right? Once you're concerned, just to pay attention and see if there needs to be some additional support for you in helping your child. All right, let's get into medication. This is something that I must say it has been a challenge, supporting people with taking medication. There is so much stigma surrounding taking medication, and as you said before, there is a reason for that based on the history.
Right.
So I guess my question for you today is, when is that necessary? And I guess sometimes it's not, but when is it necessary for people to consider taking medication for depression?
So specifically for depression, usually, and it depends on which depression, I'll say that, but usually for major depression, we try to categorize this, is this mild? Are these symptoms mild? Is this a mild impairment? Is this moderate or severe? Generally, I tell my patients, if we look at it and we're like, okay, this is pretty mild. I mean, it's impairing. They're having some impairment, but these are mild symptoms. Usually, we will recommend therapy. We'll recommend psychoeducation, trying to educate the patient as well as their parent or whoever, the adult, whoever it is. We're, doing individual therapy. And I will say this, not all therapy is the same. People think that they can just go and talk to people like, as a friend, and they think they're doing therapy. No, that's not therapy. They're talking to a friend. There are reasons why we do certain therapies. There are evidence behind a lot of therapy. So I just want to do that, because a lot of people poo-poo on therapy too. It's like, so anyway, okay. So mild, moderate, severe. Mild, generally therapy, and other things. Moderate, that's like the yellow, green, yellow, red. It's like, yeah, maybe not, depending on the person. And then if it's in the red and it's sort of like turning that orange red color, then those are the people that generally we will definitely recommend for medication, because depending on how severe the symptoms are, it can be a matter of life and death. Oftentimes when people are experiencing severe depression, they may also have thoughts of suicide, thoughts of death. And so we want to help them in their time of need, to help them improve their symptoms, because we don't want anyone to take their life. We want to keep them safe as possible.
Yes.
Generally, green, yellow, red. Green, therapy, supportive therapies, that type of thing. Yellow, you could do either or depending on the individual. Red, usually yes, we're going to recommend medication.
Okay. Well, that's good to know that you have it's not just, okay, you're depressed, here's a pill.
Oh yeah, no. And I try to meet people where they are. I understand that there, like you said, there are historical reasons. There's a lot of different reasons. People don't understand. They think that all medications are the same. For instance, and people, for whatever reason, some people where there may be addiction in the family, they're like, no pills, no medication, because they don't
I hear that
understand
a lot. That's yes.
right. You know, they don't understand that medications are different.
Mm-hmm.
And antidepressant is going to be different than, for instance, a stimulant medication for ADHD, or antipsychotic is different than an antidepressant. So they don't work the same. They are targeting different neurotransmission, neurotransmitters and things like that. They're not the same, and not all medications have a potential for addiction either. That's the other thing. So I try to explain to them the difference. I also try to explain that, for instance, in some cases, you may have one of the neurotransmitters that has been shown to possibly be affected, or one of the causes for depression may be a decreased amount of serotonin in the brain.
Mm-hmm.
Sometimes, you know, we may not have anything to do with that, because we get the genes that we get from our parents and, you know, our ancestors.
Mm-hmm.
And so that's something that we're born with. And so then when we are presented with different stressors and things like that, that may turn those genes on. So like trauma might turn it in, on certain situations might turn on. But no matter what you do, that's not going to mean that that's going to increase your serotonin in those cases where it's primarily like a biochemical thing. There's sometimes situational depression, and once that situation kind of resolves, the depression might get better.
Yes.
Right? But then there's other depressions that is really at the lowest, at the lowest level, basic level, is a chemical imbalance. And so we can wish hard and all of this stuff, but that's not going to increase the serotonin. Right? And so and so then depending on the depression, if it's psychotic depression, the treatment may be different as well. You know, so, or if it's bipolar depression, typically bipolar depression, our first line of treatment is not going to be an antidepressant, because with bipolar, remember earlier I said there's like a shift in two extremes, here and here depression, here mania. Usually with bipolar depression, we're going to try to find a mood stabilizer, something that's going to help smooth this out so you don't have those extreme moods and those extreme changes. Okay, with major depression, usually it's an antidepressant that's going to come and be used to help bring that mood up. But if you try to prescribe an antidepressant in a person with bipolar, especially if there's no mood stabilizer involved, if the person has bipolar depression, you want to get here. They take an antidepressant, it comes here, but then all of a sudden, we get up into that mania.
Yeah.
So we don't want that either. So depending on the type of depression, that will determine the type of medication that we use as well.
Very informative. Very informative. You talked about your experience with dealing with postpartum depression, and I wanted to hear a little bit more about that. Like, how did you address that? What was that like for you?
So, in my bio, you read that I have 4 beautiful daughters.
Yes.
My first daughter was while I was in residency, psychiatry residency. And here I am learning all about psychiatry and blah, blah, blah. And I'm teaching to my, patients about, stigma and all that other stuff. And then boom, I experienced it myself. It took me a while. I was a work in progress, because it wasn't until, so my firstborn is now 14. Okay. It was 2 years ago when I just had my last child. She's 2 years old. When I felt confident enough and brave enough to share with the world that I had struggled with postpartum depression, basically with each of my girls. So I myself didn't initially talk about it. What happened was, my fourth, she was my surprise baby. Well, I talked about my first one. I had complications, and that contributed to my depression. I had complications. I ended up having to go to the ICU after I delivered, and I was not, my birth plan that I created in my mind just was not, it did not happen the way I had envisioned it.
Right.
I planned on breastfeeding. That didn't happen because each time, even after I got out the ICU, each time I would try to nurse, my blood pressure would go up. And so I felt a lot of guilt. I felt shame about that. And then shame about that, I'm feeling like I'm walking around perpetrating, not being authentic. So then my last baby comes. At that time, a lot of stressors. She was my surprise baby. I was over 40. Also, and she just was not in my plan. She was in God's plan, but not my plan. That's the plan. So I had some time of adjusting because I was also making changes in my career at the same time. And so then I was doing more contract work, and then after I delivered, the plan was for me to go back to this contract. And during my leave, oh, by the way, we found someone else. Good luck. Have a good life. Goodbye. Wow. So that's those were the circumstances, the context. One day, my oldest came to me, and she said, "Mom, when are you going to go back to how you used to be?"
Wow.
And that was the moment when I was like, okay. I said I had to do something about it because number one, it wasn't helping me or my family of 6. Number 2, I am essentially modeling certain ways of how to cope and all those type of things to my children. Number 3, I am not taking the advice that I give to my patients. So it was important that I be authentic and walk the walk and talk the talk. So from there, I made some changes. Sometimes with postpartum depression, depending on it, sometimes some people will have psychosis. I did not experience that. Sometimes people will have depression or more. But depending on how severe or the type, you may engage in therapy or medication or a combination of both. So I personally have taken I took medication, and it helped stabilize my anxiety because I had like a combination of anxiety and depression. So that helped me with improving my symptoms. And then of course I tried to incorporate other things. It's just not all about medication. It's about your lifestyle. So trying to improve your lifestyle, trying to pay attention and put effort into your biological, your psychological, your social and spiritual. And so those are the things that I did. And so that's what happened with me. And so I understand where people come from. I understand the fear. And I also understand that depression does not discriminate. It doesn't care what color you are, how much money you make, what religion you are, whether you're male or female. It does not care. And you will be surprised how many people may be walking around, or people that you know and love, that have been dealing with depression or dealing with depression or suffering silently. And so I felt that it was important for me to be open and honest, and I pray that it will help inspire other people to, as I say, remove the mask that we walk around with.
Thank you for being so authentic and real. I struggle with postpartum too. I don't know if we talked about this together. I think we did, but and that was, I guess, because as you said, we do this every day. We talk to people about symptoms and how to cope. And I remember how scary it was to realize that, oh my word, I'm going through this, right? I'm feeling detached from my child. I'm like not really enjoying this. My princess, who I love dearly, right? But I quickly understood that, this was something chemically was happening to me. because of the stress, because I also had a difficult pregnancy.
Mm-hmm.
Being in the hospital for like 2 months, that just
yes. Oh my, yes.
So the good thing is, when I told my husband, because that okay, I'm feeling this way, and to talk to somebody. So that's what I did, and that helped me. Just talking about it,
Yes.
took a huge burden
Absolutely.
off my head. And I think it's so important to understand, people who are watching, that when you feel this sense of fear and confusion and this sense of shame, that is it's okay.
Mm-hmm.
And that's a normal part of it, but don't stay there. Don't stay there. Get support, seek help. It's not because you're weak or smart enough, or it's none of that. We just have a brain and we have a body and things impact us, and that's just all it is. And just owning that. So we have worked together, and it's been a pleasure working with you, because we get to see people who come in as patients struggling, not being successful in their lives and living a full life, but by working with a therapist and a psychiatrist and their doctors, they live the best life. Just to see the transformation is just amazing. So I think the main point is that knowledge is power. If you're trying to do your own things and it's not working, seek support, seek professional help. Talk to a doctor, talk to a psychiatrist, and really get support with identifying what's happening, and start the journey of healing and being in a place where you can experience life and live your best life. Do you have any final words before we part today that you want to say to people? And before you say that, I want you to tell people how to find you, and they will see it also displayed, but just let them know are you seeing patients privately? Can they reach out to you for help? Like, how does that happen?
Yes, so thank you. So if you want to reach me, you can go to www.drraushanah.com. That's DRRAUSHANAH.com. I'm also on most social media outlets at Dr. Raushanah, as well on Facebook, Instagram, Twitter, LinkedIn. I do, as mentioned, I do have a private practice, which is currently just psychiatry.
Okay.
But I also work in the community mental health sector as well. So usually with a private practice, it's cash basis right now. But with the community mental health sector, I'm able to see a variety of different people. So if you reach out to me on any one of those outlets, or go to www.drraushanah.com, then I can talk with you. I usually will offer at least a 20-minute kind of consultant or consultation, just to try to figure out whether or not this is a good fit or what direction to go into for free. So just go to drraushanah.com.
Thank you. People, you won't regret that. She's amazing. And thank you so much, Dr. Raushanah, for spending the morning with me. It was informative. It was just touching to see how you have been changing lives, and how your own life has been impacted by depression, and how you went through your recovery. So I hope that people were informed, and you're in a place where you're ready to get support if you need that. So thank you again for watching The Abundant Life today. Remember, healthy minds create happy and abundant lives. So start living in abundance today, and looking forward to seeing you again. Remember to subscribe and click that bell so you will be notified when my new videos are out. See you soon, and keep taking care of you. Take care.